Sorry, just give me 1 second.
All right, Ben. I've got the slides that you sent, just in case you can't.
Yeah. I think the other time I tried using Teams to present, the slides weren't moving.
That sounds like Teams.
Do I change like presenter mode, or do I change the window?
Do you want to look at have you got 2 screens, or is it just 1 screen?
No, just my laptop.
Do you need to see the notes bit?
No.
No. If you just put it on the normal mode, then you can either press F5 and then use Alt Tab to get back to. Oh, you've done it. Okay.
No, but say if I do this, right?
Yeah.
Are you seeing the screen
Yeah,
change?
it's working. Yeah.
So the slides are changing.
Yeah, slides are changing.
Ah, oh great, okay. Should I start?
Should we just give it a minute, Ben? I think got some people coming in the lobby still.
Yeah.
We'll probably start, Ben, because I know that you've got to go over to Salford. So thanks to Ben and Will for sorting out this learning at lunch session. Ben's one of our dermatology registrars, and he's very kindly going to go through some case studies on dermatological emergencies, which form part of the critical care RPS syllabus for sort of competencies for critical care pharmacists, but also just you can see these cases during admissions and on wards and that sort of thing. So Ben, I'll hand over to you, and thanks again for your time for putting this together.
No worries. Hi guys, my name is Ben, one of the dermatology registrars, newly working at B&B. I hope this presentation will be useful. I think from what I understand from your learning objectives is mainly to find out what are the common drug culprits, but then that that presentation will be very short. So I thought if we run through some cases, that might make it a bit more interesting. So the first case, you've got a 45-year-old woman presenting to A&E with a sudden onset of severe facial swelling, red, painful eyes with discharge, crusting, erosion of the lips, and you found query non-blanching purpuric rash, predominantly on the chest, upper and lower limbs. And I've got a photo. Does anyone have any thoughts about what this might be, just from looking at the photo? I can't really see the chat and stuff, so if you've got an answer, you can speak into the microphone. If not, upon thorough history taking, it's reviewed that she's been taking ibuprofen 4 hours prior to admission for flu-like symptoms 3 days ago. She has no past medical history and no other sort of significant history. Observations, she's a little bit unwell, temperature is up, but otherwise, you know, and her sort of breathing is also up as well, but otherwise not too bad. On assessing her, you've noticed some conjunctivitis, some coalescing red erythematous targetoid-looking macles with a central blister formation on the face. There's swelling, erosion, and yellowish discharge on the lips. And she's got the same sort of targetoid-looking lesions on the upper and lower limbs, and it's less than 10% of the body surface area. When you did some investigations, she's a little bit anemic. White cells are raised inflammatory markers. Kidney function slightly off. Everything else is sort of negative. And then I appreciate that histology isn't something that you guys necessarily deal with every day. But I put the skin biopsy here because it would actually help lead us to the diagnosis. So on the skin biopsy, it showed full thickness necrosis and separation of the epidermis at the dermal-epidermal junction. So at this point, does anyone know what the diagnosis is? Will, if you're on the chat.
I think I should refrain from giving answers because I've already looked at your slides, so I know what the
Oh,
answer is.
right.
I've looked at your slides as well, Ben, so I'll keep quiet.
Right. So the diagnosis is Stephen Johnson's. The histology of full sort of epidermal thickness necrosis, that is in keeping with SGS or TN, usually TN. You don't really get that full thickness necrolysis in erythema multiforme, if that is what you were thinking of, just because of the targetoid lesions, and the fact that there is mucosal involvement would push it more towards SGS-TN. There is a subvariant of EM. I mean, EM is split into EM minor and major, but I wouldn't go too much into it. Just know that if you're suspecting anything on a spectrum, although erythema multiforme, SGS-TN are distinct entities, but if you're cautious that any of these presentations may be SGS or TEN, then you prepare for the worst thing, which would be TEN. In this case, the patient was admitted to ICU, and this is what they did for her. There was supportive treatment with IV fluids. They gave some prophylactic antibiotics just because of the mucosal involvement. They gave lubricating eye drops for the eyes, mouth care for the oral lesions. They actually gave prednisolone, and I'm not going to go too much into this, but I think prednisolone for SGS and TEN is a bit contentious, but I will talk to you about that later. Analgesia is very important for these patients as well, just because it will be sore if you have any erosions or mucosal involvement. And in her case as well, she also got an NG insertion to help with oral hydration. And actually, she was discharged after 7 days and followed up by dermatology and ophthalmology. We've got a second case. So you've got a 44-year-old man that presented to A&E with an acute onset itchy rash that was widespread over his trunk and limbs. And upon, oh, and sorry, and I forgot to mention just now the case, for case one, it is likely secondary to ibuprofen. So that was the only thing that was salient in the history. So the ibuprofen, sadly, the once dose of 800 milligrams has caused her to look like that. I'm not saying that it happens in all cases, but just be mindful. So for case two, you've got this 44-year-old man with an acute onset itchy rash that was widespread over his trunk and limbs. Upon thorough history taking, you found that 3 weeks ago, allopurinol atoracoxib with ibuprofen was given for gout. He was seen initially in the community with a more sort of benign-looking rash. At that point, they thought, well, let's give him some pred to see if it helps, but unfortunately it didn't. When he came to A&E, this is his observation, so slightly worse than the woman before, is borderline hypotensive, he's tachypneic, his O2 sats are low for someone without COPD, his heart rate is up, temperature is up, and when you look at him, there is symmetrical confluent erythema on the trunk and face with flaccid blisters, and it is involved about 50% of his body surface area. The medical team stretched his skin, and he was Nikolsky's positive. So Nikolsky's sign is when you apply sort of tangential pressure next to like an area of skin involvement, which could be, in his case, epidermal detachment. And then when you pull on normal skin surrounding that skin as well just comes off. And And then when you looked at his mouth, there is multiple erosions with a whitish coating and scabs. And again, it's got sort of some eye mucosal involvement. And this is after actually, sorry, it's after he got admitted. But when you looked at his skin, this is how it looked like. So it's not very nice. Investigations, however, didn't look too bad. His CRP was elevated. He had a mild AKI. Chest X-ray was normal. Blood cultures were positive. I think epidermidis, sorry, is a commensal, but logdunesis, might be pronouncing it wrongly. That isn't a commensal. And he was subsequently also positive for MRSA and VRE on skin swabs. At this point, does anyone know what the diagnosis is? We've briefly talked about it. And I'm so sorry, I can't see any written replies. So a diagnosis of TEN was made, and a score 10, which is just a prognostic sort of criteria. On admission, it was 2. I'll talk about the score 10 later. But for this case, the guy was admitted to ICU. He had supportive treatment with IV fluids, wound care, non-adhesive dressing. The same thing. If you've got eye involvement, there's simple eye care. If you've got oral involvement, simple oral care. Apparently, in this case, they had a special bed with air fluidized therapy. I think this case was a paper written in France. I don't know if in the NHS, in ICU, I mean, at least the ICU in Salford that I worked with, I don't think we have special beds with air fluidized therapy. Apparently, it promotes recovery and wound healing. But otherwise, he's also received systemic corticosteroids. It would be either prednisolone, or if he's sedated, which I presume was in this case, he would have had methylpred. They also gave antibiotics just because of the blood cultures. And even if his blood cultures weren't positive, with that level of skin involvement, you would probably have some sort of prophylaxis ongoing. And remember that even though the patient's in ICU, they're probably sedated. If they're not like fully sedated, I guess it's been a while since I'm in ICU. Just make sure that their analgesia is on top as well. Oh yeah, I did mention it here. So in this case, unfortunately, from 50% body surface area, it went up to 80%. And what happened was they actually stopped the prednisolone and they gave a single dose of infliximab, which we can briefly chat later. And the infliximab actually helped stop the progression. Well, let me rephrase that. I'm not sure whether the infliximab stopped the progression or whether it's due to discontinuation of the the medication that he came in with, the allopurinol, the etoricoxib, I think they stopped all of that right on the onset when they were suspecting TEN. So we don't know fully whether it's the prompt discontinuation of all those medications or whether your transient dose of steroids plus this single dose of infliximab, don't know how much that has added on to actually halting the progression. But from an ICU point of view, he obviously his other organ systems got worse. He was started on BiPAP. They also sedated him to optimize his management of restlessness and hypertension. And actually, he was successfully extubated on day 18, and he had full re-epithelialization of his skin in 4 weeks. And then MRSA and VRE was found to be negative after that. So actually, he made a remarkable recovery. So SJS and TEN, SJS stands for Stevens-Johnson syndrome, TEN for toxic epidermal necrolysis. It's a life-threatening mucocutaneous reaction. It's almost always drug-related, sometimes due to infections or immunizations. So I think I've written below, it could be associated to mycoplasma and CMV. And the mortality for TN is actually quite high. I'll briefly mention the score 10 criteria later. Both these conditions, they could present with poorly demarcated, so ill-defined, dusky, sort of dark purple gray looking macules, papules, patches, or plaques. So just for context of the non-dermatology staff, macules would be sort of flat lesions, papules are slightly raised, patches are sort of larger macules, so just but they're flat, and then plaques are larger papules, they're raised like a plaque. Or like a plateau. And then all these could subsequently form bullae, and they form bullae. They're not typically known as bullous diseases, but they can form bullae, as they're transiting to frank or full epidermal detachment, because of the necrolysis that's happening underlying. And just for the context of everyone as well, I appreciate not everyone would be there physically to review the patient, but I told my colleagues this as well because I gave another talk on drug reactions before. If you see anyone that is suspected for a drug reaction, um, and on your skin, let's say they haven't reached the stage where the skin is sort of peeling off, they haven't reached that stage yet. But when you look at the spots and you see that they're dusky looking, on histology, it's theorized that the dusky looking areas would correspond to scattered apoptotic keratinocytes. So your skin's basically the dusky areas are representative of query skin cells already dying, but not in that great amount. So this in itself could suggest that there might be incipient or like underlying worsening, that will be, soon to progress to actual frank epidermal detachment. So if your medical team, says, oh yeah, this person can be discharged, maybe ask them think again if it's still looking very dusky and you're worried. Otherwise, the lesions often start on the trunk, and they spread elsewhere. And then for the context of SGS and TEN, there will be mucosal involvement for both, and they're usually painful, and they can involve the eyes, they can involve the mouth, they can involve the genitals. To be fair, they can involve everywhere that has a mucosal surface, and if it involves like respiratory, GI, cardiovascular, then obviously it's much worse. SGS and TEN is on a spectrum, so if you've got more than 30% surface area, that's TEN. If you've got an overlap, that's 10 to 30%. It's less than 10%, then it's SGS, so that's the spectrum. And then score 10 was just the sort of prognostic sort of scoring criteria, which I wanted to highlight to everyone. I personally don't feel like it's all that useful because most people that come in to hospital anyway, they'll be older than 40. So then they'll score 1. So at each one of these 7 variables, they'll all score 1. And then if you look at the case that we've got, his heart rate was 117, but it's not that difficult to get the heart rate up if you dehydrate it. Body surface area would already be more than 10% if you're suspecting, TEN. If they're dry, urea probably more than 10. And if they've got, I don't know, kidney involvement, or if they're just a bit acidotic, whether it's respiratory or metabolic, the bicarb might be already less than 20. If you're starting them on steroids, the glucose will go up. So in itself, they would probably score relatively high on the score 10. And the context is if you score 3 or more, that's already more than 30, 34, 38% mortality. And then 4 points out of 7 is already more than 50% mortality. And if you score 5 out of 7, that's a 90% chance of that patient dying from TEN. So the main point is that if you've got if you've got a patient that your team is suspecting of TEN, you know that the risk of mortality would be significantly great, and you should not downplay these conditions. Complications of SGS and TEN, I've written a whole list here. It's non-exhaustive, but basically most of these complications, sorry, are pertaining to the sort of scarring and adhesions that form when your skin sort of heals from SGS and TEN. So if you've got sort of eyelid or eye adhesions, scarring, you might get your eyelid turning out, you might get them not closing properly. I think the rest of them, eruptive nevi nil dystrophy, it's not that great, so I don't know why I put that here. But alopecia, again, not as worrying, but for the long-term context, maybe blindness would be worrying. There are other complications that I did not mention here, which are also significant. So if you've got sort of urogenital sort of adhesions, strictures, or scarring, that might be bad. If you've got, again, scarring or adhesions in your respiratory mucosa or GI mucosa, that is bad as well. But the treatment for SGS&T and is actually really simple. All you need to do is stop the offending drug and give them supportive treatment. Well, when I say all you need to do, but these are the mainstays of treatment. So I think prognostically speaking, even the number of days between like identifying SGS&T and stopping the drug, prognostically, that has a significant correlation to mortality. So even if you identified it like a day late compared to 3 days later, mortality changes a lot. And I can't recall the exact percentage, but it is a lot. It's more than like 20-30%. So it's a big difference when you actually stop the drug right on time. I think this list is the most important to yourselves. I hope you found the rest of the talk so useful. But for SGS&T, and I think what I want you guys to take home is if you forget all the different kinds of medicines, which you guys probably wouldn't. I would, but you guys wouldn't. Just remember like the 4 A's: antibiotics, anticonvulsants, antifungals, allopurinol, and then NSAIDs, which are commonly incriminated in a lot of problems. And in the case of SGS&T, again, antibiotics in the form of sulfonamides. I know there are other different non-antimicrobial sulfonamides. For this context, just remember the sulfur-containing ones, like cotrimoxazole for antibiotics. You've got beta-lactam antibiotics as well, penicillin, cephalosporins, anticonvulsants, lamotrigine, carbamazepine, phenytoin. I don't believe we use phenobarbital that much. At least I've never seen it being prescribed before. And you've got antifungals like terbinafine, and I think terbinafine is something that we give quite commonly as well, and not necessarily in an ICU setting. But I've learned from my dermatology consultants that they do they do what's that word? When they're prescribing terbinafine to a patient, they do warn them about the potential risk of SGS&T, and allopurinol is another one, NSAIDs we talked about. I left paracetamol and acetaminophen there, just because it is mentioned in the literature, but then we give paracetamol so much anyway, so just take it with a pinch of salt. And then nevirapine, which is an NNRTI, I think used in HIV and other things. But yeah, so this is the list of offending drugs for yourselves. And before I move on to case 3, I just wanted to say for SGS&T, and there are other forms of treatment that we use. So correct me if I'm wrong, but I presume that if the ICU team or if the dermatological team wants to consider other forms of treatment, they might discuss it with yourselves because they probably wouldn't be the most comfortable in prescribing complex regimens. So in literature, pulse corticosteroids, like whether it's oral pred or methotrexate, IVIG has been used before, but this might be outmoded now, I think. But in the past, people do use IVIG, and it's IVIG more than 2 grams per kilo. I think that's the dose that they used that was found efficacious. Infliximab, so TNF alphas have been tried as well. There are other things that have been tried as well. I think like cyclophosphamide and other medications, but I won't go into that. But it may be the case where if the patient, I guess, looks like crap, and then although you know that the mainstay of treatment is discontinuation of the drug and supporting. Sorry, is someone asking a question? No? Right. So I was gonna say that although you guys will know from this lecture now that the mainstays of treatment is discontinuation of the drug and supportive treatment, it might be that at some point, 2 or 3 days in, patients still crap, and then they might start thinking, oh, is it worth doing any of those, extra regimens? They probably will already give steroids, or I don't know, cyclosporin, things like that. But stuff like IVIG, infliximab, they will probably pick your brain later into the admission if the patient was still appearing quite crap. At least that's what my understanding is. The other thing that I wanted to say, although I didn't write it here, was if the dermatology team or the ICU team is very enthusiastic sorry, if they're very enthusiastic with giving corticosteroids, just be mindful that it is still a form of immunosuppression, and the mortality that's associated with SJS and TEN, it's not purely from the skin involvement. It's mostly from infections. So just be mindful that if you're giving systemic corticosteroids or any of the other wonderful immunosuppressive alternatives, that you might be um, increasing the risk of them having a concomitant infection, which will then kill them. But it's difficult, so everything is based on clinical judgment, and you weigh risk and benefits anyway. Like if you're a patient with SJS and T, and say the culprit drug wasn't something so easily stopped like allopurinol or NSAIDs, if it was a patient that came to ICU and he has HIV, and you're giving him a sulfur-based antibiotic for like Bactrim for PCP pneumonia, and he looks crap, he's in sepsis because of this, then I would defer that discussion with the ICU consultant and any other sort of MDT representation to see what's the best way moving forward. So case tree, slightly different because the previous two cases were people who presented to A&E and then got shipped up to ICU. But I thought, let's do a case where the patient's already resting on ICU. So this is a 53-year-old woman with biliary sepsis in ICU. She also has a background of hypertension and end-stage renal failure. And just to make things more complex, she already had 2 failed renal transplants. Now she's on ICU because she has a undulating sort of journey with this biliary sepsis. And what we've done as medical people is we've chucked her with lots of antibiotics, which is correct. I'm not insinuating that it's wrong, but we've chucked her with many courses of antibiotics to try and help win with her biliary sepsis. And this is a small chronological picture of all the different kinds of antibiotics which she's got. So I don't need you to look at the precise amount of antibiotics, but just know from this picture that this lady's got lots of antibiotics: tazocin, amikacin, ceftriaxone, vancomycin, imipenem, and then that would make sense. So following this huge amount of antibiotics, she actually had a benign looking rash in day 29. After 2 hours of being seemingly okay, she then developed a high fever and she had distributive shock. And you loaded her with some, sorry, and then you started her on a noradrenaline infusion. And then afterwards, the rash actually developed into erythroderma, so that's more than 90% of your body surface area being involved. And she's got lymphadenopathy. She's got raised eosinophils, and her white cells have now dropped with a relative lack of neutrophils. And this is what you see on ICU. Does anyone have any clue as to what this diagnosis is? We'll just move on. So a diagnosis of DRESS or DIHS was made. DRESS stands for drug reaction of eosinophilia and systemic symptoms, and DIHS stands for drug-induced hypersensitivity syndrome. And what they did was they stopped actually all the drugs that were introduced at least 10 days before the rash was stopped, except for the vasopressors. Vancomycin was replaced by linezolid, and they gave methylpred. And then when they did further investigations, they found 30% eosinophils in the bone marrow, which will be in keeping with drug reaction of eosinophilia and systemic symptoms. And the EBV load was elevated because most commonly in patients with Tourette's, you've got reactivation of sort of viral problems like HSV, EBV. So the condition actually improved within 10 days. There was some desquamation and blistering, but then the skin healed. There's still the eosinophilia and the agranulocytosis actually normalized. And I think what happened in this case was the ICU and the derm team thought that thought that the culprit drug was vancomycin. So what they did was previously they switched it to linezolid, but then when the lady got unwell again with Klebsiella pneumoniae, they gave her tazocin because they thought the causative drug was vanc. But unfortunately, after they reintroduced tazocin, everything went south again. This eosinophilia, neutrophils went down, lactate went up. There's viral reactivation again, and when you did the bone marrow biopsy, it just concurs with what you suspected. So the culprit drug was identified to be Taz, and then further management, Taz was stopped, methylpred was increased, and the condition improved within 2 weeks. But unfortunately for the eventual outcome of this patient, she died on day 102. So from the initial picture anyway, she spent about 30 days before we diagnosed her with RES. She was 30 days with biliary sepsis. So I think from that front, her prognostication isn't very great. This case was just to highlight that given the complexities yourselves face in ICU, that the chance of a patient in ICU developing a drug reaction, I would say, I didn't look into the literature, but I presume an average patient in ICU would have a higher risk of having an adverse drug reaction compared to a patient on the ward, just because the chance of switching medication would be higher, the chance of starting a medication would be higher, the chance of them being on a complex sort of regimen will be higher. ICU, you hear a lot of beeps every few seconds. Although your nursing ratio is much better, but the environment, take it with a pinch of salt. I'm not saying this in a negative way, but the environment might be more disruptive. Your patients are much more sick, so the pharmacokinetics, of an ICU patient would be more significantly altered than that of an average ward patient. Like in this case, your patient has end-stage renal failure, and then she's her body surface area, with although its skin is not peeling, but she probably has other sort of derangements as well. So and if there's liver involvement or if there's kidney involvement, you're not going to clear them properly as well. So then all together, I just feel like it is what it is. It's just more difficult on ICU, and I just want everyone to be mindful of that. So DRESS or DIHS, it's a serious hypersensitivity reaction to a drug. And the one that you need to take note is that it typically takes about 2 to 6 weeks after starting your offending medication. If I did not mention that earlier on, for SGS and TEN, the time interval is about 7 to 21 days, so about 1 to 3 weeks. So DRESS is slightly longer. So when you're going through someone's drug history, you might have to dig further back, just because anything from 6 weeks ago might also contribute to DRESS. But there isn't a hard and fast rule. So, unfortunately, sometimes we do go all the way back to 2 to 3 months and then take it with a pinch of salt, because not everyone will remember their medications. If they're old, probably won't remember when they actually started it, and unfortunately, LPRES is not very useful. But I'm sure you guys have other ways of checking in with their primary care physician as to when a new medication was actually started. But DRESS is characterized by cutaneous eruption, fever, lymph node enlargement, with internal organ involvement. So that's why you get your elevated liver enzymes, you might get kidney impairment. And for DRESS, peripheral blood eosinophilia is um, like uh, like a hallmark as well for DRESS. And you usually get patients with a morbilliform eruption, which may then become more edematous with follicular accentuation, typically involves the upper trunk, extremities, and face. And also in DRESS, um, another hallmark is facial edema. And treatment is similar for all drug reactions. You stop the offending drug, and then you can consider corticosteroids and or other things on discussion with the dermatology consultant or the ICU consultant. And then, since I've spoken so much anyway, as an extension to DRESS and DIHS, the histology is actually not very relevant in DRESS, just because if you actually did a skin biopsy of one of those lesions, it could be very variable. It could resemble a plethora of different sort of drug reactions, and it won't necessarily be supportive of DRESS. It might rule out SJS and TEN, which I guess in most cases that's why people would do a biopsy, but it wouldn't necessarily help you diagnose DRESS in that sense. And then this slide would probably be the most important for yourselves. Antibiotics, anticonvulsants, allopurinol, again, the same few culprits. You also have olanzapine, dapsone, and abacavir. Yep. This is something that I found online and in textbooks. It says that if the time interval between symptom onset and the initiation of a culprit drug, if it's within 2 weeks, you're thinking more of beta-lactam antibiotics or contrast media. If it's more than 2 weeks, then you can consider anticonvulsants or allopurinol. But I would just say consider everything. It's not, again, all of these things are it's not a hard and fast rule, and that if it's within 2 weeks, it has to be a beta-lactam antibiotic. So case for last and final case, we've got a 61-year-old male who presented to A&E with a 1-week history of progressive, diffusely red rash within the skin folds and intertriginous areas. So that would be like your armpits, your groin areas. Past medical history, he's morbidly obese and he's got significant sort of cardiovascular risks. He tried putting some topical nystatin because he thought it might be like an infection. And then when he went to A&E, the doctors thought he had intertrigo, and they thought he had erythrasma. So erythrasma is sort of a bacterial infection. I forgot which bacteria. I apologize. But the medical team started him on oral erythromycin and fluconazole, and knowing the theme of this lecture, you suspect what's going to happen next. Within 3 days, the patient's rash then spread diffusely across his trunk and extremities to form papules and sort of lots of macules everywhere. And then all the papules actually coalesced to form plaques. There was no mucosal involvement. And actually, within 12 hours of the worsening rash, he acutely decompensated. He became short of breath. He developed metabolic and respiratory acidosis, and he needed to be transferred to ICU. He was then started on BiPAP and even intubated, and then started on vasopressor support, and also developed sort of shock liver and in AKI from the sepsis. So this is what the rash sort of looks like. And then when you did investigations, you found sort of blood eosinophilia. There was an AKI of hyperkalemia, but in the context of the AKI. and there was raised sort of liver transaminases as well, but also in the context of sepsis and AKI. Chest X-ray was fine, they did a CT, it's fine, cultures were fine, skin swabs were fine, and on a skin biopsy, which actually gave the diagnosis, you saw diffuse spongiosis, which just means sort of inflammation and edema sort of in the skin. But you found numerous subcorneal pustules, and that actually leads us to the diagnosis of AGEP, or acute generalized exanthematous pustulosis. So in his case, I think it's a bit tricky because I presume the man rightfully would have had Candida, and possibly even had erythema, but unfortunately, because we gave him erythromycin and fluconazole, we iatrogenically caused the AGEP. It's not anyone's fault. I think it's still clinically appropriate. Then it is a risk, so long you warn patients about the risk of drug reactions. But in his case, and it's tricky as well because you'd expect Candida or erythema to be in the intertriginous areas, and AGEP could also present beginning from the intertriginous areas. So there is that clinical difficulty. But in any case, he was given antibiotics initially, but then the workup was negative, so it was stopped. And then for the drug reaction, he was put on steroids. And actually, he showed marked improvement. He was then extubated on day 3, and actually, he had complete recovery on day 4. So just to briefly go through, AGEP is a drug reaction often seen 1 to 2 days after starting a drug. You see numerous pustules. They're not like infected pustules, they're sterile pustules. Just because your neutrophils are collecting under your skin in little pockets. And they appear initially in the face or intertriginous areas. They resolve typically in 1 to 2 weeks, and you get blood neutrophilia if you've done just routine bloods. There is a validation score. I'm not going to go through it. Treatment, again, is the same with all drug reactions. The number one thing is to stop the offending drug. And in AGEP's case, more than 90% are drug-induced. I won't hold your time too much, so I'm just going to skip. So the offending drugs, again, antibiotics, anticonvulsants, antimalarials, antifungals, calcium channel blockers. I put that in bold because that's something that we give quite commonly as well. I put the sulfonamides in asterisks as well. It's because for AGEP, the non-antimicrobial sulfonamides might predispose to AGEP as well. So if anything, the take-home message is you need to promptly discontinue the offending drug if you're suspecting that that's the drug. If you're suspecting that there's a drug cause to the rash that you're seeing. I mean, obviously it's tricky, but if you look at it and you really heavily suspect that, you do need to stop it. So if your primary team says, no, we'll wait for dermatology, but in the context of ERHT, you might not get dermatology reviewing, not even in the same day. It might be 2 days later. So really, you do need to stop the offending drug if you're suspecting that it is due to the drug, especially in the context of SGS and TEN. And then common culprits would be antibiotics and anticonvulsants, NO, allopurinol, antifungals like terbinafine or NSAIDs. You get a very high mortality with SGS and TEN, and I think for the CCU context as well, just take note that your patients are at a high risk for adverse drug reactions to the various reasons which we've mentioned before. And so my references, and that's it. Any questions?
Thanks, Ben. That was really useful. Just a question for me. In terms
Yeah.
of like the different treatment options, are there like British Dermatological Society guidelines on TEN and SGS?
Yes. I think I didn't want to go through that in depth,
Yeah.
but there is a I think the BAD has recently updated guidelines for TEN. That's what my consultant told me. I haven't had a chance to look at it. I apologize. But I think till date, management of TN, it's still not that well looked into, just because of the mortality of it. And you can't devise like an RCT with TN people, and the mortality as well is quite high. So I think that's why it's a bit difficult. And if you look into the pathogenesis of it, I might be digressing, but if you look into the pathogenesis of TN or SGS, it's still not that well explained. It's not like it's not like your drug hypersensitivities where it's type 1. I mean, it is classed as type 4C, I think. Type 4C hypersensitivity. So like a delayed cell mediated sort of type. But then on the same measure as well, when you do that biopsy, you don't see that much inflammation under the skin. It's it's more so something has happened between you ingesting the drug and whether it's the drug or the metabolite, possibly interacting with the immune system, and that's triggered some cascade where your skin cells just start becoming apoptotic and they're dying. Um, and I don't know if there's much inflammation along this whole pathway. So, but then again, with regard to steroids, I'm digressing as well, but I'm not sure steroids themselves, how do they interfere with the immune pathway, like whether they reduce, some sort of interleukin or some sort of cytokine, I don't really know. But from a pure anti-inflammatory point of view, then I would argue I'm not so sure if steroids are that relevant in SJS and TAN.
Thanks, Ben. Yeah, that's really useful. Has anyone else got any questions for Ben?
No.
No, that's fine. If anyone does think of anything, then I can email you, Ben, and Will, if that's
Yeah,
okay.
yeah.
So thanks so much for taking time to
No
join us
worries. I
today.
hope I hope it's useful because I wasn't exactly sure if all the clinical bits were um if you guys would find them relevant. But
Yeah,
then
I think it's been really useful to see the different because I think when people come up to ICU, they're either diagnosed with 10 or SGS, and it's very very unclear. But I think because you've gone through the 4 different case studies, it's a bit more clear as to what sort of things you're looking out for now. Well, certainly in my opinion, in terms of what I've come across before. So it's been really
yeah,
useful. So thanks so much for putting
no
that
worries.
together and taking time to do that on behalf of all of us. Um, and yeah, if anyone's got any questions for Ben and Will in the future, then please email me and I'll get in touch with them. But yeah, thanks so much, Ben, and thanks
No
everyone for
worries.
joining us. Have a nice afternoon.
Right. Take care. Bye.
Thank you, Ben.
I didn't start off like that though, so there's like anything going on that is preventing you from coming to work on time.
Do you know what it is though? I think it's learning how to have the conversations.
But like sometimes, like but sometimes it's a case of some people just take the piss. So you have to figure out who's actually being genuine with saying like, yeah, there's things going on at home and blah blah, and who's just saying it comes in all your false off and go, oh okay, yeah, don't worry about it. Yeah. Kind of need to pick up at it.
Your new starter sounded a bit sassy when she asked you if you had children.
I know.
Jack,
I've had like 14 emails off of today.
that's what I'm a little bit scared of. Like, if I've got someone else, someone who's got like, not making excuses with their kids, but like, if they're like, well, you don't have kids, like, you don't understand.
I know, but it's the same, like, you have pets, you do have pets, it's the same with your pets.
Yeah.
When your pet's poorly, like, you want to be at home with them. Okay. Just looking through the book and I realised I must be practicing spellings. Email, untrue, thank you, step 2, having you crawl, wheelchair.
Oh.
He's my little sex spot.
Do you want me to just turn it down because she's not in here?
I've never known anyone snack with watches.
Oh my god, yeah. Snacks all the time. She also loves. She's got 2 apples, pack of crisps, more apple, banana.
Not judging.
Sugar. Again.
Not judging. Just successful, have 2 L's on the end.
One second. No.
No, just one. Thank you.
I thought it was on, but then I'm also pretty shite.